So I thought what I would do is talk a little bit about the usual protocols that we use to diagnose rejection in pediatric transplant patients, but then maybe through doing that, show you some future directions that we might want to think about and hopefully stimulate some ideas. So pediatric heart transplantation is obviously not a super common procedure. There's only about 700 performed annually, but it's obviously critically important for those children who have no other treatment options. Survival's really good early. So the 1 year survival of a child who's had a heart transplant is about 90%. And the indications for transplant, you can see there on the left in a figure from the International Society of Heart and Lung Transplant Registry, with most transplants in children being secondary to either dilated cardiomyopathy, congenital heart disease, and then a smattering of retransplants and other myopathies. When you think about median survival, it seems good when you think about how this compares to adults who've had a heart transplant. If you're an infant at the time of transplant, infants survive on average up to about 22 plus years. That's average survival. So there are certainly some that survive much longer, but teenagers only survive around 13 years. And when you think of that in the spectrum of a lifespan or expected lifespan of a child, that really isn't very good. So we certainly have a long ways to go. When thinking about rejection, it's obviously one of the most common complications that we see. About 15% of recipients have an episode of rejection in the first year post-transplant. And that certainly is the time when rejection is the most common, is in that first year. And we do know that early rejection is associated with poorer survival. So looking at this Kaplan-Meier curve, again, from the International Society of Heart and Lung Transplant, if you look at it at survival conditional on survival to 1 year post-transplant and divide patients into those that are free from rejection the first year versus those that have an episode of treated rejection within the first year, you can see there's a significantly lower survival in patients who are treated for rejection in that first year. So it's important for us to diagnose it. It's even more important for us to treat it. But even then, some of this goes beyond our control. So what do we do with these routine surveillance biopsies? Well, when we talk about routine surveillance biopsies, we're really talking about detecting asymptomatic acute rejection. So routine and surveillance, implying that this is a scheduled procedure. There wasn't anything clinically that drove the need to do this biopsy. We're really trying to catch rejection prior to any sort of symptom or change in graft function. There's a really high prevalence or high variation, I should say, in practice across institutions and across centers as far as how many biopsies are done. Here at Children's Hospital Colorado, historically, we've been a really low biopsy center, meaning we try to do as few as possible. In our infant population, we don't do any biopsies until 1 year post-transplant, and instead monitor for rejection primarily by using echocardiogram. And there's some controversy as to the benefit of routine surveillance biopsies in recipients who haven't had a history of prior rejection, especially as you get beyond that 1 year post-transplant. So if an individual is beyond a year post-transplant and hasn't had any rejections, is there much benefit to doing these biopsies serially over time, or are there other ways of monitoring for rejection? The complication rate of biopsies is something that we obviously worry about, especially in small and younger children. There is the potential for complications. I would say the most common complication we see, which is still less than 1%, is injury to the tricuspid valve, so valve trauma. But we can cause all sorts of problems, arrhythmias. We can damage the conduction system, of course, vascular occlusion or injury, hematomas at the puncture site. These are all things that happen when you're doing a biopsy in the cath lab. So the way these biopsies are done is the interventionalist or the transplant cardiologist inserts the bioptome either through the right internal jugular vein, typically, or through one of the femoral veins. And we thread this bioptome, which is shown here, up into the right ventricular cavity, and we try and take biopsies from the right ventricular surface of the ventricular septum. And this bioptome works by these little pinchers. And so you engage this bioptome on the surface of the ventricular septum and then take a bite, pull the bioptome out, and put the biopsy on the table and go back in and do this again. And we typically do about 5 of these when we're doing a rejection surveillance cath. The interesting thing, and one of the challenges, is that over time, the bioptome tends to go into the same spot on a recipient's heart. And so, when you get 10, 12 years down the road, getting a biopsy that has viable myocardium to evaluate can actually become a little challenging, and you end up just getting scar tissue sometimes. And there have been patients where, I've had to kind of go in, and we're talking on the 15th try, you're still just getting scar tissue. And it gets a little sketchy there because you're trying to move the bioptome around to get to a more viable spot on the myocardium, but that certainly increases the risk that you're going to puncture through the apex of the heart, or you're going to grab a chordae from the tricuspid valve and damage the valve. So it gets a little more challenging as time goes on. So I'm just going to run through a few slides showing you the different kinds of rejection and just some pictures of the types of rejection that we're trying to diagnose. So there are really 2 forms of rejection that we need to diagnose in a pediatric transplant recipient. This is the same for adults. There's acute cellular rejection, and then there's acute antibody-mediated rejection. Cellular rejection is mediated primarily through lymphocytes. ISHLT has come up with a grading system, which they update every so often. You can see that in the table here, with 0R being no rejection, and then 1R being mild rejection with some interstitial infiltrates of lymphocytes. So you can see on the top slide here, this is really just a normal piece of myocardium. And with 1R, you can see this area of lymphocytic infiltrate, where you've got some lymphocytes infiltrating into the interstitium, and there is some associated myocyte damage there. 2R is moderate cellular rejection. So instead of having just one focal area of myocyte infiltrate, with the 2R rejection, you've got 2 or more foci of infiltrate. So you can see on this more zoomed out view here, there's 4 or 5 areas here where the lymphocytes have infiltrated into the myocardium. And then 3R is a diffuse infiltrate with multifocal myocyte damage. You can have edema, you can have hemorrhage, you can have vasculitis, these kind of more advanced pathologic signs associated with 3R rejection. I would say 3R rejection more typically is associated with graft dysfunction. So these are sometimes the more obvious, rejectors. I wanted to show a picture here of just more of a zoomed in view where you can see this higher power image where these lymphocytes are kind of chewing on the myocytes. That's what we mean by myocyte damage. So, to get to having this differentiation between, resident lymphocytes that may be intravascular versus these infiltrating lymphocytes that are chewing and damaging the myocardium is something that is important for us to see, but you can just kind of see some of these eating away at these myocytes. And then this is just an example of some of these scarred down biopsy samples we can get. I mean, you can see how much scar there is on this piece here. There's just very little myocardium for us to even look at. So trying to detect rejection when you have these tiny little pieces of myocardium attached to scar is almost impossible. In this case, there are 2 good pieces here, but only these other 2 pieces have a lot of damage. And again, you can imagine that we may miss a spot of rejection. This is kind of a blunt tool to try and diagnose rejection. When you're getting these tiny pieces from the myocardium, you very well could miss an area where there's lymphocytic infiltrate. So I think that's why the idea that there needs to be a better way of diagnosing rejection that's a little bit more global, that we can use to detect rejection early, not waiting until there's evidence of changes on echo, is really pretty challenging, actually. So antibody-mediated rejection is the other type of rejection that is important for us to identify. This is kind of a newer understood and newer defined form of rejection. And so it was only in 2013 that ISHLT put out this pathologic diagnosis kind of scoring system. So there's PAMR 0 through 3. And the way this is done is there are histologic findings that are associated with antibody-mediated rejection, and then there's immunopath findings. And the immunopath findings are based primarily on C4D staining, which C4D is a degradation product of the complement pathway, and then CD68 staining. Some people do. I would say that's less commonly done. That's a macrophage marker. So I'll show you some of the pictures here. But basically, the grade has to do with whether or not there's just histologic evidence of AMR, just immunopathologic evidence, a combination of the two, and then again, kind of severe disease or severe rejection with hemorrhage and edema and other findings. So when thinking about the histopathologic signs associated with AMR, one of the things we look for is interstitial capillary injury. You can see these very prominent and swollen endothelial cells. Hopefully you can see that here with these little arrows. The nuclei are very enlarged, and sometimes the cytoplasm seems to even just narrow the lumen of the capillaries. Intravascular macrophages can really fill up the capillaries and some of the venular lumens. And this is where CD68 staining can be useful to demonstrate that these really are macrophages, because sometimes it certainly can be difficult to tell what type of cell these are. But when you can see these macrophages present in the lumens of the biopsy, that makes us concerned about antibody-mediated rejection. Edema, you can see here, these kind of proteinaceous material within the interstitial space of the biopsy. And then inflammation. So you can see inflammatory cells other than macrophages. This can be a little bit, there certainly can be some crossover here where you can have a mixed rejection with lymphocytic infiltrate demonstrating cellular rejection and then antibody-mediated rejection on top of that. But some other cells such as NK cells, specifically neutrophils, eosinophils can also be contributing. Looking at the staining that we do, so positive, when we get a report back from our pathologists here in Colorado, what they'll tell us is there's either positive or negative C4D staining. And when they tell us there's positive C4D staining, they'll kind of qualify that a bit by telling us if the staining is multifocal or diffuse, and whether the signal is weak or strong. And I'll show you some examples of that. But importantly, I think these can be sometimes tricky to read. You really need a pathologist that's experienced in doing this, and big transplant centers certainly have that. But you want to make sure you're looking really at specific interstitial capillaries. We don't want to be looking at arterial or venular staining. We really want to be looking specifically at the capillaries and whether there's C4D staining around these capillaries specifically. And then we want to look at the intensity. Is this a weak or a strong staining? You can see there's a grading system here from 0 to 2+, with really, very strong staining here in the 2+, and kind of a middle of the ground here with the 1+, and then the distribution of the C4D staining. So is it focal, is it multifocal, or is it diffuse? And that is really defined primarily on the percent of the biopsy area that has positive C4D staining. So again, that's kind of how this gets reported out to us as clinicians. So CD68 staining, I just wanted to show one slide here so you can see what it looks like. We looked at this image earlier, but there's this kind of positive cells that are restricted really to the capillary space are the ones we want to count, and maybe the small venules that look chain-like, kind of linear or beating. And, we know that there certainly are macrophages that are resident within the heart. And so there has to be a significant number of these in order to believe that there's positive CD68 staining. So you have to have more than 10% of intravascular macrophages to really consider this to be associated with antibody-mediated rejection. And if there's more than 50% of the biopsy demonstrating evidence of multifocal or diffuse intravascular macrophages, that's even a higher grade of AMR. I just wanted to show this study to this group because I think it's really kind of cool and interesting. This is a study done by Brian Feingold, where he looked at these morphometric whole slide imaging using NearSight in pediatric transplant recipients. And he did this really kind of from a prognostic standpoint. So he selected patients who have graft dysfunction. So their hearts are sick, they're not doing well, and he wanted to kind of characterize what the tissue looked like. And he looked at it in a few different ways. He used there was CD31 staining done on the biopsy samples. And then again, using this automated NearSight system, the system was able to detect the capillary density. So the capillaries are everything circled in red here. The CD31 is staining the capillary nuclei. And then there's the percent fibrosis. So he used trichrome to demonstrate the collagen occupied areas of the biopsy, and they were able to used this NearSight system to kind of quantify in the whole area of the biopsy what percentage was fibrotic. And then he looked at microvascular spacing. So he looked at the number of capillaries that were within the center of a nucleus of a myocyte. So in the red here, there's a myocyte nucleus, and then how many capillaries were within 30 micrometers of each of the different myocytes. And then he also looked at something called capillary diffusion distance, where they determined what was the closest capillary to an individual myocyte. And what he found is that patients who had poor graft function had a higher degree of fibrosis, which isn't that surprising. But he also found greater capillary diffusion distance and a higher proportion of myocytes with zero capillary neighbors. So there was this kind of microvascular abnormality where you just had lower vascularity of the myocardial tissue, which is interesting. So, we are always interested in trying to find less invasive ways of diagnosing rejection, especially in children. Most of our patients are young. When they go have a cardiac cath and need to have a biopsy done, they need anesthesia. This is obviously stressful for the family, stressful for the patient. And so, we do think that echocardiograms obviously offer some ability to detect rejection, but while the negative predictive value is very high, there's pretty low sensitivity. Cardiac MRI, I think, is evolving, and I do think this has some merit, but the results so far are a little bit disparate. Some studies show pretty good detection of rejection, others not so much. And again, this doesn't help us from the standpoint of young children who still need anesthesia to undergo a cardiac MRI. And then there are biomarkers, of course. So we look at donor-specific antibody to detect the titer of HLA antigen antibodies that are present. We can look at C1q binding of those antibodies to demonstrate that they have a higher potential to be biologically active if they bind complement. There is a commercial test called AlloMap. There's a couple of these now with gene expression profiling. The problem is these are limited to older children. They haven't been studied in the young patients. And again, high negative predictive value, but not such great sensitivity. And then a really rapidly evolving area is donor-derived cell-free DNA. So donor-derived cell-free DNA can be detected by a blood test. Normally in a recipient, there's less than 1% of the circulating DNA that is derived from the donor. But if that number increases, then that's suggestive of active damage to the allograft. And this could be, I think, a pretty promising area for us, given that it's just a blood test and has been linked in adults with pretty early detection of rejection. So just a couple last slide here with just a couple future directions to maybe think about. One is optical molecular imaging. So this has been done a couple of different times. The picture here on the right is from a publication from Circulation many years ago, but it's kind of a cool concept where they developed these microbubbles that target lymphocytes. They injected, this is a rat model, they injected these microbubbles into the tail vein of the rat, and then they allowed the microbubbles to kind of infiltrate into the myocardium, attached to lymphocytes, and they measure this signal at baseline. Then they do a flash pulse, which then disrupts all the bound microbubbles, and you can detect the difference between the baseline pulse and the pulse after the signal intensity pre-pulse and post-pulse, and determine how many of these microbubbles were actually bound to lymphocytes. So kind of a cool idea of being able to do this in a less invasive manner and detect actually lymphocytes within the interstitium of the myocardium. And then there have been some animal studies using bioluminescence imaging. This may not be as useful in humans, but you can imagine maybe PET imaging and things like that could be used to detect evidence of activated lymphocytes within a graft early on. But Dr. Sanders' talk got me thinking even more about the potential, especially with engineers in the room, of nanoparticles and exosomes, which may hold pretty good promise. And these nanobubbles that these investigators used as an example of that. The advantage of nanoparticles and exosomes is they can get through the vessel wall and into the interstitium of the heart. And so one thing I thought about when Dr. Sanders was talking is whether there would be a way of engineering an exosome that has something like connexin, a connexin antibody, or something linked to some sort of dye that you inject into the vasculature around the AV node, and would that light it up and stain the AV node? That's total. I have no idea if that would work, but just kind of an interesting thought I had while he was talking. But the same idea of engineering exosomes that could tag macrophages that are in the in the capillary space within the myocardium or lymphocytes. So just to bring this to a close, certainly biopsy remains the gold standard for diagnosing acute graft rejection, but it's by no means perfect. We are always interested in non-invasive ways of diagnosing rejection, and think this certainly could improve the quality of life of our youngest patients, especially. And then any sort of novel imaging and biomarker approaches that we can identify to detect rejection, especially in its early stages before there are symptoms or graft dysfunction, obviously could help us improve outcomes. So thank you very much.